All right, so I'll start off with a couple of questions that we've got so far and give people some time to write down other ones. Okay. Yeah, so the first one is requesting comment on red wine as a strategy or an asset to maintaining a healthy heart.
Right. Well, red wine has the grape skins that are in red, the grape skin compounds that make it into red wine as opposed to white wine have beneficial effects on your arteries. So those are polyphenolic compounds, and alcohol of any kind raises your HDL a little bit. Bonnie told me not to put that on the slides, that regular alcohol consumption is also one of the protective factors for preventing heart disease. It's not as strong as exercise or a healthy diet. But so if you are a responsible drinker and you have 1 or 2 glasses of wine a day, any alcohol or 1 or 2 drinks a day, it may help your heart. And the red wine may have some additional benefit separate from other types of alcohol. Somebody, question in the back. Well, as I said, you can raise your HDL a little bit with any form of alcohol, but red wine seems to have some additional protective effects on your arteries.
Okay.
Follow up.
Would you recommend supplement resveratrol?
Right. So resveratrol is one of the compounds present in the red wine skins, and some research suggests that it increases the function of cells called mitochondria, which is a good. You want to have lots of mitochondria functioning in your cells, and there is some evidence that it may have anti-aging processes. So I think we're still learning about resveratrol. So it does appear to be beneficial, but I can't recommend a dose or anything like that just yet.
Okay. All right, we'll go on to our next question. And some other risk factors that weren't mentioned are C-reactive protein, homocysteine, and fibrinogen. So how would they fit into the picture of cardiovascular disease risk?
Okay, so there are other blood factors that are being studied that can help further refine a person's risk for heart disease. One of them is called C-reactive protein, and it is a measure of the amount of inflammation you have going on in your body. So if you have arthritis, for example, you may have high CRP. If you're a smoker, you may have high CRP. So any place of inflammation in your body can lead to an increase in CRP level, and high CRP seems to be connected with risk for heart disease. So what that's telling us is that inflammation is a risk factor for heart disease. And we know that people that have rheumatoid arthritis or lupus or other types of like psoriatic arthritis have a higher rate of heart disease. So it's adding an additional tool that we can measure. If we've had a hard time making a decision about treatment, we're not measuring CRP in everybody yet. Homocysteine is a protein breakdown product that we used to think was a strong risk factor for heart disease, but it turns out that lowering homocysteine with vitamins doesn't actually reduce your risk of a heart attack or stroke. So it's kind of been taken off of our list of important things to look at. Fibrinogen is a clotting factor, and there is some evidence that a high level of fibrinogen can increase your risk for clotting and therefore heart attacks. But it isn't as strong as our other predictors. So we're not measuring fibrinogen routinely in our clinic.
Okay. Now, Bonnie, in your talk, you I assume it targeted smoking tobacco, but smoking other things or other forms of tobacco, like chewing tobacco or smoking marijuana, do these things have a risk relevant to heart disease? And if so, how?
Yes. Smoking anything produces that carbon monoxide. So whenever anything is lit, be it marijuana, be it homegrown tobacco, it's producing the carbon monoxide, which, when it's inhaled, causes the inflammation of the lining of the arteries, making it easier for the cholesterol to attach. And when it comes to chewing tobacco, it's not inhaled, but there's certainly a high incidence of oral cancers from it, and you're certainly getting the same chemicals, which, when they're ingested, can also cause the same inflammation as the carbon monoxide that's been inhaled.
Okay.
So, and the other thing too is cigars, which still seem to be holding their own in popularity, and they're very high in nicotine. They're at least 3 times higher than cigarettes, and depending on the size of it, can be much more than that even.
Okay, great. So there's a couple questions that kind of relate to each other about statins and cholesterol treatment. One regarding about Lipitor, whether it's your thoughts on it as an anti-cholesterol drug, and then regarding kind of pains that can be elicited as a result of statins, and maybe you can answer. The last one is Dr. Francis says, which pharmaceutical company is closest to developing an HDL therapy?
That's a lot of questions.
But I thought they're all related. So
Okay. So one of the main therapies that we use to help reduce the rate of heart attacks and strokes are the statin drugs, and Lipitor is one of them. So in people who have already had a heart attack or stroke, we know that lowering the bad cholesterol down to quite a low level, like under 2 millimoles, will help significantly reduce the risk of having another heart attack or stroke. And even now in people who haven't yet had a heart attack or stroke but who are at high risk for a coronary event because of their age or their family history or their cholesterol level or blood pressure, smoking, the risk of heart attacks in people treated with statins like Lipitor is significantly reduced. The main side effect of statin medications are muscle aches and sometimes muscle damage. So whenever we ask somebody to take a statin, we warn them that the main side effect can be muscle achiness. Happens to about 5 or 10 to 10% of people who take them, and if that happens, they should tell us, and we would reduce the dose or stop the medication if they can't tolerate even a lower dose.
And then the HDL?
So HDL raising therapies are hotly sought after, and not just in my lab, unfortunately, but in many researchers and companies around the world. And so we believe that if we have a way of increasing HDL formation, that would be a major breakthrough in our ability to help prevent heart attacks and strokes.
Okay. All right. Good. Was there a follow-up?
Well, the main way that statins work, so the question is, are they a diuretic, meaning do they make you pee more? And I haven't heard that, actually, but and my patients haven't told me that. But so that's interesting, because there's lots of side effects that I learn about all the time. But the main way they work is by inhibiting cholesterol formation. In the every cell in your body makes cholesterol, as well as you get more cholesterol from your own body making it than you do from your diet. And so if you reduce the production of cholesterol, especially in the liver will remove more cholesterol from the bloodstream because it needs lots of cholesterol for its functions, and that's why your LDL goes down.
Okay. So back to smoking. Many of us either know or are related to people that smoke. So if we were trying to, let's say, get a close family member to stop smoking, what things can we do to motivate them?
It's tough. Well, pretty well all smokers report that One thing that puts them off and makes them dig in their heels is when a family member is on their back. So, I think it's a matter of, putting in some positive suggestions. Anything from, gee, it's great, I see you haven't had a cigarette for 3 hours. It's some positive reinforcement, but, sometimes it's a case of discussing finances, and the other partner can really resent the $300 a month on cigarettes. So it's individual, but, positive reinforcement and not riding them too hard to get them to stop. Sometimes if you can get some written literature, that just a pamphlet that lists the harms from smoking, that can be helpful too, that they can just read on their own and realize that, there really are problems that could be around the corner from smoking.
Okay, great. Okay, so Dr. Francis, in your talk you mentioned about diabetes, and so is there equivalent risk or different risk, whether it's type 2 versus type 1 diabetes?
Yeah, so most diabetes is type 2. So that is the type that adults get, and it's often associated with obesity or overweight, and in particular increased abdominal fat. And it accounts for 85 to 90% of all diabetes. Type 1 diabetes is juvenile onset. It's the type where you need to go on insulin immediately, and it's due to an autoimmune destruction of the pancreas cells that make insulin. So there isn't the same kind of inherited predisposition to type 1 as there is with type 2. If you've got a family member who has adult onset or type 2 diabetes, that's where you have a 50% chance of getting it at some point in your life. So my father developed diabetes in his 70s, so I have a 50% chance of getting diabetes. So I have to keep exercising.
Is that why you went into endocrinology?
No, but I...
Sorry, that wasn't down
anyway,
there.
Yeah.
Okay. There's a couple questions about the Healthy Heart Program, how it's administered. Is it open to the public, or is it only open through physician referral?
So it's usually based on physician referral. We have some people who refer themselves, and the goal is to help people realize and reduce all their risk factors for heart disease. And we now accept referrals just for smoking cessation, for example, or for if somebody has pre-diabetes but not official diabetes. You don't have to have a cholesterol abnormality, for example, to come to the clinic.
Okay, right. So I'm not sure which of the two would be best to answer this question, but how do we deal with stress, the increased risk due to stress, and how can we get family doctors to start talking about it to patients?
Well, stress definitely, as Dr. Francis mentioned, is an independent risk factor for artery blockage. And they say the first step is recognizing what's stressful for you. So, for example, in a household, what's stressful for one person isn't necessarily the other. And also, if you have been continuing on with your life, you may not even realize what's stressful for you. It may be very vague. And so, the first step is recognizing what is stressful and then figuring out what you're going to do about it. And some things you have choices. You can leave something or change it. But other times you don't have a choice. And so then it's how to manage it the best you can. And so, for example, if you were working and let's say there was something stressful at work in your day, well, then that would be a day for sure you wanted to make sure you had a lunch break, and maybe you can take a walk on your lunch break. So first of all, you have to identify the stress for you and then figure out what you're going to do about it. And there's basic things like, making sure that you're eating well, getting enough sleep, exercising. These are all things to keep you finely tuned. And then after that, just, trying to deal with what's stressful for you individually.
Okay. There's a couple questions on atrial fibrillation and questions about dealing with swollen legs and raising the legs. Is that helpful? And is there any, to either of your knowledge, any connection between alcohol and atrial fibrillation?
Okay. Well, neither of us is a cardiologist. We'll just say that right off the bat. And although we work in the Healthy Heart Program, we're not seeing people specifically for atrial fibrillation in our clinic. But so usually if you have atrial fibrillation, you may have been referred to a cardiologist, and your atrial fibrillation can be controlled just by reducing your heart rate, whether or not the rhythm normalizes, or sometimes you can have an electrical stimulus that will help normalize your heart rhythm and get you out of atrial fibrillation. Increased alcohol intake is a risk factor for inducing atrial fibrillation or worsening it. So it is a factor. Did you want to?
I was just going to say, with alcohol, if it's excess for that person, it can cause what they call cardiomyopathy, enlargement of the heart. So you have the original electrical system in the heart, but you've now got this enlarged heart. And so the electrical system is firing, but because the heart's enlarged, it's not responding the way it used to. And this is when the people show, the atrial fibrillation.
So when you mentioned, Dr. Francis, about abdominal obesity, so is there is fat in other areas good, or does it still carry a risk to
butt
it?
fat is healthier than gut fat. So people sometimes put fat on in other parts of their body, and it doesn't seem to be as dangerous as when you have increased fat around your belly and your intestines. And the reasons that belly fat is more dangerous aren't exactly known yet, but the belly fat seems to release more inflammatory mediators that can then damage the arteries than say butt fat, for example, to put it politely.
Okay. Yeah. All right. So looking at the nicotine patch, if somebody's taking this, does this affect things like the nitro patch or beta blockers? If so, how?
Yeah, no, it doesn't. It's fine. You are getting a slight increase in heart rate from the nicotine patch, which is much less than if you were smoking. So the beta blocker you're taking to lower your heart rate, and the smoking would have your heart rate much higher. So the nicotine patch it's an accepted solution, even if you have heart disease, active angina, and what's the other one?
Beta blockers.
The one other one.
There was just two, the nitro patch and the beta blocker.
Oh, okay.
Yeah. Okay. All right. The I guess $60 million question is, if you have hardening of the arteries, can it be reversed?
Okay, so the answer is yes.
Okay, there we go.
So you can, if you reduce your risk factors, you can stop the progression of plaque enlargement, and by addressing all of the risk factors, including reducing blood pressure, quitting smoking, lowering cholesterol, we do actually see shrinkage of blockages in arteries over time. So it's
Attention visitors, the time is now 8 p.m. and visiting hours are now over. Thank you for visiting and have a nice day.
You don't have to leave yet.
No.
So it's never too late to start reducing your risk factors for heart disease.
Okay, good. What role does fish oil have in cholesterol management?
So fish oils are the same as omega-3 fatty acids. They're synonymous, and they reduce the fats in your blood, the triglycerides. They don't really lower your cholesterol, however. So they're not a good treatment to lower cholesterol. But in people who have high triglycerides or fats in their blood, they're a good triglyceride lowering agent. But they also seem to have other protective effects on your arteries, independent of their effects on triglycerides.
There's a couple of questions on presentation of angina. Maybe if one of you wants to just describe how angina may present itself in what areas of the body.
Okay, so angina is defined as pain that you get because you don't have enough blood flow going through the little arteries that feed your heart muscle, and those are called the coronary arteries. They're small arteries that feed the heart muscle. And that's what people get disease in that leads to heart attacks, is these coronary arteries. And the pain, well, the symptom you feel when your heart muscle is not getting enough blood flow, it can be, that's what we call angina. And the typical feeling of angina is a tightness of your chest, a squeezing sensation, and it can go up to your jaw. It can go down your arm. But in some people, and a lot of women in particular, don't feel typical angina. They may feel heartburn, or they may feel some back pain, or they just may feel nauseated or unwell. Do you want to add anything to that? Have I forgotten any possible ways that angina can present? Right. So it can be just something you feel in your throat or in your jaw. It can be just shortness of breath when your heart muscle's not getting enough blood supply. When you're walking up a hill, you might just become very short of breath, but you won't feel the pain.
Is it possible that because sometimes angina is, though the sensation isn't necessarily angina or heart specific, like people can have heartburn and get it. When you mentioned about women in the back in some of the areas, is it possible that somebody with like a pinched nerve in their back could present with pain that may or may not be like a differential diagnosis for angina, or get confused with that?
Yeah, it can be confused with other problems, and if you have an existing medical problem, you might be attributing the pain you're getting to that problem when actually it's your heart. And sometimes people just feel very unwell, and they don't have particular heart symptoms, and if they go into emergency and their heart's tested and they're found to be having a heart attack. So,
okay,
it's not always obvious.
Okay, so what advice then for people who might be just going straight to their doctor or to the emergency?
Well, I think if you're feeling very, very unwell for any reason, it's a good, and it's not getting better, it's a good thing to be checked out.
Yeah. Okay. With statins, we talked about that they can affect muscles and muscle pain. If somebody's experienced that and the CK level is elevated, is there any contraindications or changes into what people might be able to do for exercise?
So is the question then, if you're having statin side effects and it's limiting your exercise, then what should you do about it?
Or if the CK level is high, should somebody hold back on their exercise because of this might be doing double damage or a concern to the muscles? So
when you're put on a statin medication, one thing your doctor might follow up when he's retesting your cholesterol levels is to look at your muscle enzyme level, which is called the CK level. And it might be high, and if it is and you have muscle pain or muscle achiness, then that's an evidence that maybe the statin is doing some damage to your muscles, and then you stop the statin and the aches go away and the CK comes down and you see that there's an obvious connection, then maybe you don't take the statin or use a lower dose. A lot of people on statins have muscle aches, but they don't have high CK level. So you don't have to have a high CK level to believe that the statin might be giving you the achiness. If you stop the statin and the aches get better, it's probably a real side effect, regardless of your CK level. Most people with statin aches don't have high CK.
And would people find that the aching would actually be a deterrent for being active, or?
Some people find that their exercise tolerance is lower. They get achier sooner than they would because of exercise than before they were on the statin. And that's a real side effect, and you should tell your doctor and possibly reduce the dose or even take the statin every other day.
Okay. Bonnie, you'd mentioned about quitting and something about vacations. So that if somebody's going on vacation, they might want to postpone their quit date. Why would that be?
Well, it can work one or two ways. I mean, I guess if you were going to Europe where smoking is at a much higher rate, you might want to rethink that. But the idea being that a lot of times when people take vacation, they're just out of their usual life. So presuming that, their life is a little bit less demanding, the usual triggers aren't there. And so sometimes that can be an easier time to pick a target quit date. When you're out of your usual surroundings and not doing your usual activities and around the same people.
Okay, good. So we have a diet question. So I don't know who wants to.
You should take it.
Well, okay. So we'll do our best to answer this question. We work with dietitians. And see how much by osmosis we've got. In general, recommendations from studies saying that having eggs a few times a week are okay. And on the one hand, they're a good source of protein. On the other hand, the egg yolk contains cholesterol. So how does this cholesterol have much of effect that comes with an egg on our body's blood levels of cholesterol?
Yeah, I think what our dietitians recommend to people is if they're used to having 2 eggs every day for breakfast, for example, and they've got high cholesterol, then we would ask them to go down to maybe just twice a week kind of thing. You don't have to eliminate all eggs from your diet. But yes, dietary cholesterol does have an effect, and it can come from eggs or it can come from red meat in particular. And so we do if we're trying to help people lower their cholesterol using dietary measures, then we do suggest reducing sources of cholesterol, which all come from animal products. You don't get them from vegetable products, cholesterol.
Now, with looking at if we do measure a cholesterol or lipid profile, there's a bunch of different numbers. Is there a way, if things like your total cholesterol, triglycerides, good cholesterol are within value, can some of these values, if they're within a desirable range, counteract, let's say, a high LDL or values that are in undesirable ranges?
So I think I would interpret that question to mean that if you have a high level of bad cholesterol, but you also have a high level of good cholesterol, are they canceling each other out? Is that sort of the question? And I think if you look at whole populations, so big studies that have been done on thousands of people, they do indicate that. So if you have a high level of HDL, it reduces the risk of a high level of LDL, and that's why that ratio is very important. But not everyone with high HDL is protected against having a heart attack. There isn't a 100% correlation. So some people with high HDL still have heart attacks. So, but when we assess people for whether or not they might need to be on medication, and they have high LDL, but they also have high. If they have high LDL, but they also have high HDL, then we may do things like looking at their arteries to see if there's any blockages forming, And if they aren't, then it looks like that HDL is protecting them, and then we wouldn't put them on medication necessarily
And
to lower the LDL.
If the LDL is low, is there a value of LDL that might be considered too low? Have we got there?
Yeah, I mean, a lot of studies on heart disease patients have looked at lower and lower LDL levels and seen whether reducing the LDL to further low levels reduces the rate of heart attacks. And it appears that below about an LDL of 2, the rate of return of reducing heart attacks further is relatively small. But medication-induced drops in LDL, I don't think they lead to increased rates of cancer or anything like that. So I don't think we are lowering LDL to such low levels that we're causing other disease.
Okay. And if somebody has like low HDL, since we're limited in our ability to raise it until you finish your research, what would be a strategy then?
So when people have low HDL, that can be their only major risk factor for having a heart attack, actually. So there are families with low HDL who get more heart disease, even though their bad cholesterol is not so high. So we do things like encouraging aerobic exercise, maybe using niacin, and the HDL might come up or it might not. And if that's the case, and they have known heart disease, then what we try to do is lower the bad cholesterol further. So we improve that ratio of bad over good cholesterol.
And this might be a question for both of you. Mentioned that heart attack symptoms may present differently between men and women. What other factors are unique among the genders with respect to heart disease that we should be aware of? We know that the Heart and Stroke Foundation has made a big public campaign towards promoting awareness for heart disease as the number one cause of death in women. So what kinds of things should we be looking for?
Separate from men.
Yes.
Well, I think women have to realize that when they reach menopause, their estrogen levels go down, excuse me, and their risk goes up at that time. So, and I think just being aware of all the risk factors. In the past, the theory was that women pressed on with their symptoms, and so, didn't report them. And I think that's kind of changed now. A lot of times it's the other way around. The feeling is that women are going more to their doctor for their symptoms as opposed to men. So I'm not sure that that's anything, but basically, as Dr. Francis says, women can often have the indigestion or a feeling of fatigue, which I know sounds pretty general, and who doesn't, but just that general feeling of fatigue and recognizing that whatever it is, it's not your usual, and so going to the doctor to report that. But, women can still have the typical chest pain, heaviness, pressure, a symptom down either arm, all the usual ones.
And when we look at, just empirically from my perspective, when we look at, people in the Healthy Heart Cardiac Rehab Program, it's obviously dominated by men in that, but women are equally or still have risk for heart disease. So what might be some of the factors that you might attribute to that differential?
Well, you hope that the percentages of women referred are the same as men. The other thing is women are traditionally known as the caregivers, and so, are they too busy in their lives to be able to have the time to come twice a week to cardiac rehab for the exercise program? It's hard to say because it's an older age group, and so they have traditionally had a role where they have had, responsibility for family and household. So there's still a bit of that thought that as to one of the reasons why women attend cardiac rehab in lower numbers.
Okay, all right, great. I think I've gone through pretty much all the questions that we've received, or some variation of that. We have one coming down. Any? Sure, yeah. Having an angiogram done outside, like whether that's you mean whether it's better or worse or any different? Okay, so if somebody had differences in if somebody had angiogram traveling outside of Canada, how that might be interpreted? Is that here? Okay.
Well, I think that the way of doing angiograms is relatively similar around the world. So if you can get the results, back to your doctor in Canada, then I think it would still be useful. Yeah.
Okay. I saw there's some questions coming down. Yes.
What's your thought on caffeine?
Caffeine. So I hope there's nothing bad about caffeine. And every time I hear something good about caffeine, I breathe a sigh of relief. It seems to have a lot of these good polyphenol compounds in it that are protective against heart disease. And have you heard anything bad about caffeine that you're worried about? Yeah, it may be the risk from drinking coffee might come from the sugar and cream you put in it than the caffeine, the coffee itself.
No, I've heard that it does cause your heart disease.
Well, it does. If you drink a lot of coffee, it will speed up your heart rate, and so that we do advise people that have heart rhythm problems, like atrial fibrillation or a rapid heartbeat, to not drink too many cups of coffee or tea each day.
Now, going back to some of the possible muscle damage as statins, is that affect heart muscle similarly? Is that a concern?
Yeah, the muscle damage from statins seems to be more in your skeletal muscles, your arm and legs and whatnot, and it can present with achiness or sometimes weakness or even loss of muscle bulk over time. So if you are experiencing any of those things while taking a statin, you need to tell your doctor, because it's not always pain, for example.
Okay. That question
at the back there.
Yeah, I used to put in years ago, I lost the Healthy Heart program, and I was on the treadmill when I had surgery, and after that, the treadmill was my training rate would be between 100 and 130.
Mm-hmm.
Now I have increased it. Okay, like my age is 70, and now I've increased it up to maybe 140, 150 at the top. I guess I'm going to my own tune, but
So you're worried maybe you're going too fast?
fast or
Yeah.
whatever it is.
Well, I think if you've gradually built up your fitness level and you're not experiencing any chest pain or tightness with that intensity of exercise, you're probably okay. I mean, if you've had your heart tested again at all by other tests like a stress test or a MIBI scan, and things are all right, then I think if you're gradually improving your fitness level and you can go that high without symptoms, it's probably okay. But I would talk it over with your heart specialist. And as I said, Bonnie and I are actually not cardiologists. We're masquerading as cardiologists here tonight. But we try to prevent heart disease before it happens, you see.
So we don't need cardiologists.
No.
That's right. Wondered if you could just do a brief synopsis of this slide, Dr. Francis, on the psychosocial stress.
Well, yeah. So, we know that, stress comes in many forms, and in this study, they did some very detailed questionnaires about stress and how much control people feel they have over their lives, and what factors are leading them to have stress or depression. And these are standardized questionnaires that they use to quantitate it, and they are validated questionnaires. And by doing that carefully, they did find that stress was the third strongest predictor for risk for heart disease. So I think it's probably the thing we do least well in our clinic, and also in terms of management. We're still not very good at helping people manage their stress. Bonnie gave good examples, and whether we have enough psychologists to go around, I think we all have stress in our lives, and how we deal with it is something that's learned over our lifetimes as well. And but recognizing that stress is a major risk factor by itself is important. So when we find people who are having, that they're very depressed or they feel very stressed, and it's not just situational, maybe their job is in jeopardy or whatever, then we do refer them to a psychologist in our clinic.
Bonnie, maybe you can answer this one. In terms of how long after, that's kind of a double question, how long after a heart attack would it be recommended for somebody to start cardiac rehab? And when should we start looking at introducing exercise like walking or running and so forth?
Well, generally, if someone has angioplasty at St. Paul's or bypass, bypass is going to be a little slower recovery because of the surgery, but angioplasty, they're usually in the hospital just for one night. So after that, usually a person can start walking, if they feel able, and the physio at the hospital would give guidelines. And then usually we would try to get you to the cardiac rehab within a month. Sometime it's 6 weeks. But you come for initial appointment to see the cardiologist, and then if he feels that you're fit, you have a stress test. And that's a maximal stress test. So from that, they're able to calculate what your training target heart rate should be. So then you come back to the Healthy Heart Program, and you would meet with an exercise specialist, and he or she would have calculated where you should train. So that within the 6 weeks when you start in cardiac rehab then, they're teaching you about the equipment, how to use it safely, the importance of a 10-minute warm-up before exercising on the equipment, and then you would be hooked up to telemetry, the portable heart monitor, and they can see your heart rate in response to the exercise that you're doing. And so everybody's different, but based on their stress test, for example, if somebody's target heart rate was 100 to 125 and their resting heart rate was 60, then they should take a full 10 minutes to go from 60 up to 100. And then after that, they're exercising in that target heart range of 100 to 125. Now, for people that don't have diagnosed heart disease, they're just wondering how hard they should work on the equipment, we recommend the Borg scale, which, if you remember, is the sing, talk, gasp scale. So after that 10-minute warm-up, where you're gradually bringing your heart rate up, if you can sing, it's too easy. If you're just gasping, it's too hard. You should be able to talk. Not a rundown on how your day's been, but a few coherent sentences, slightly into the gasp. And that would be considered the level to work out on your gym equipment. Walking outside is a little bit less, you don't have to worry about intensity the same unless you've got some real hills.
Okay. Yes, yes.
I had some cardio work a couple of years ago, and I had a new valve and some ablation and bypass. So even after that, they reckon I'm still high risk, and possibly because it's an artificial valve. Foresee
Well, yeah, the valve the valve replacement corrected that problem. But if you had a bypass, it means that you have evidence of blockages in your arteries, and because you had it, you are at risk for getting more blockages. So that's why you would still be called high risk. So then it's important to keep your diet healthy, exercise, keep your cholesterol down. Yeah, so that's a separate heart issue as well, but yeah.
So, again, going back to cholesterol medication, is it safe to have like a 20 milligram pill for let's say Lipitor and cut it in half and take it? And when would be the best time to take the medication?
Okay. So I think part of that question is related to the cost of the medication. So, and we do, if people don't have drug plans, for example, then we sometimes do prescribe a higher dose tablet that they can cut in half and thereby reduce their cost by half. So it is okay to take a half a tablet of something. If your doctor says it's, so if it was a 20 milligram Lipitor and your cholesterol values are looking good with 10 a day, then it's fine to cut a tablet in half, yeah. Okay. And then the time of day. So for the older statins like Zocor, it was recommended to take them at night, and because your body makes more cholesterol during the night, so you inhibit the cholesterol production. The newer statins like Lipitor or Crestor have longer. They work longer in your body, so that it's not so necessary to take them at bedtime or at nighttime. You can take them in the morning, and you have pretty much the same effect. But if people remember, the best thing is taking it when you remember to take it.
Yes.
If it's easier to remember in the morning, that's good. If night, then
the prescription doesn't work if you don't fill
that's
it.
right. Yeah, or take it.
Yeah. And is there any with the newer statins, is there any contraindication towards grapefruit juice?
Yeah, that's a good one. It's generally thought you shouldn't go near grapefruit if you're taking a statin. I think it's okay to still have a half a grapefruit a few days a week, even on a statin, as long as you don't go on a grapefruit diet or something like that. And there's less interaction with Crestor, for example, than there is with Lipitor.
Okay. And another cholesterol question is, how often should a healthy person have their cholesterol tested?
So what our guidelines suggest is that men, if men have reached 40 without any major risk factors, so they don't have family history, they don't smoke, we can test them every 5 years. And for women, it's after 50, every 5 years. However, if you have family history of heart disease, or if you're a smoker, or if you already know you have high cholesterol, or you have high blood pressure, any other major risk factor leads us to test people earlier.
Okay. And just coming to the last couple questions. So Dr. Dean Ornish in California has a very aggressive way of reversing artery disease through meditation, exercise, low-fat diet, and so forth. What's a kind of general opinion towards that regimen, because it's such a difficult thing for the average person to follow?
Yeah, I think if you are very strict about how you eat, and you eat very low fat, but still get enough protein and vitamins and minerals, and you can reduce your stress very well, You can cause regression or shrinkage of your plaques just with lifestyle factors. But if you have genetically high cholesterol, then lifestyle factors alone are not going to give you a normal cholesterol. So it depends how much time and strictness people are willing to have in their lives with their diet and exercise, and how much time they can spend meditating and whatnot. So it has to be realistic for your life.
Yeah, and again, it I guess comes down to the same thing with the medications. If you can't remember to take it, if you don't can't follow the regimen, then it's not going to do any good anyway. So, last two questions. One's talking about polyunsaturated fatty acids. Is there any implication or effect on HDL cholesterol?
Yeah, we haven't identified one diet component that really has a big effect on HDL. So unfortunately,
in a positive way or negative?
Even a positive or negative way, there aren't enormous effects of different types of fats on increasing HDL or dropping HDL.
What about trans fats? We hear about that.
So trans fats they're more. They get stuck in your arteries more readily, and they're more likely to cause blockages, independent of what they do to your HDL or LDL level. So that's why they're now being taken out of foods.
Okay.
Yeah.
And in a question, I guess, related to the statin-induced myopathy, what role does coenzyme Q10 have?
Yeah. So one of the molecules you inhibit the production of in your body when you take a statin is coenzyme Q10. So people take a supplement of that sometimes, and it does reduce muscle aches in some people. So when it's tested against placebo in big trials, it hasn't been shown to have a significantly different effect on muscle aches, but it does seem to work for some people. So if they try it and it works, then that's good.
Okay. And so there's, just before we go, there's some healthy snacks outside. I assume they're healthy. Half healthy, or half of it is healthy. The next session for Own Your Health is on May 19th, and that's dermatology, love your skin, skin aging, and skin cancer. Dr. Gillian DeGanis is going to be speaking. And I'd like to, again, thank our presenters, Dr. Gordon Francis and Bonnie McNaughton.